Bismillahirrahmanirrahim. This question number 47. A 16-year-old girl whose pubertal breast changes commenced about 4 years ago and has episode of lower abdominal pain lasting about 3 days each month for the last 12 months. She has not yet had her first period. Abdominal examination when she is not in pain shows no evidence of any suprapubic mass or tenderness. Blood tests have shown that she is ovulating. Which one of the following developmental abnormalities is most likely to be the cause of her abdominal pain? So, this 16-year-old girl with whose pubertal breast changes commenced about 4 years ago, and she had a lower abdominal pain lasting about 3 days each month. Means every menstrual cycle she had this pain, which is for last 12 months. And on abdominal examination, she is not in pain. At that time, examination was there was no evidence of suprapubic mass or tenderness, and blood tests have shown that she is ovulating. So, which of the following developmental abnormality is most likely to be the cause of her abdominal pain? An imperforate hymen, an absent vagina but normal uterus, a transverse vaginal septum, mullerian or paramesonephric agenesis, a uterus obstructed at the level of the cervix. So these are the options: imperforate hymen, an absent vagina but normal uterus, transverse vaginal septum, mullerian agenesis, a uterus obstructed at the level of the cervix. So the monthly pain could be that associated with ovulation or could be due to obstruction to the outflow of menstrual loss from the uterus. In this instance, tests have shown she is ovulating, making either of these causes still possible. Had obstruction to menstrual flow been the cause, as could occur with an imperforate hymen, absent vagina, a transverse vaginal septum, or cervical obstruction. It would have been expected that the retained menstruation would have resulted in the presence of suprapubic mass, the hematometra or hematocolpos, but no palpable mass was evident on abdominal examination. So the correct answer is Mullerian agenesis would result in no endometrial development and therefore no palpable mass and no menstrual loss to be shed. This diagnosis would be confirmed by the performance of pelvic lower abdominal ultrasound examination. 35-year-old woman present with a cyclical mastalgia. Clinical examination of the breast is normal. Her mother developed breast cancer at the age of 45 years and subsequently died from metastasis. The patient's maternal grandmother also had a breast cancer before the age of 50. The patient is on oral contraceptive and no other medication. Her general health is normal. Mammography is normal. An ultrasound of the breast shows an uncomplicated cyst with no concerning features in the right breast. Apart from advice about the use of simple analgesics and evening primrose oil for her mastalgia, which one of the following is the most appropriate advice in this patient's follow-up regime? So the options are C's of oral contraceptive pills, yearly clinical review, yearly mammography, and ultrasound. Remain on the oral contraceptive, yearly clinical review, yearly mammography, and ultrasound. Remain on the oral contraceptive pills, 6 monthly clinical review, yearly mammography, and ultrasound. Remain on the OCP, 2 yearly clinical and mammography review. Cease the OCP, yearly clinical and ultrasound review. Breast cancer is a common disease. About 1 in 11 women in Australia will develop a breast cancer by the age of 75 years. Patients such as this woman with a family history of breast cancer in more than one blood relatives, parent, sibling, grandparent have a significantly higher likelihood of developing breast cancer than women with no family history. Regular 6 monthly clinical review and yearly mammographic screening with or without additional ultrasound screening should begin at least 5 years before the age of the diagnosis was made in her blood relatives. Consensus now would be that any additional risk from the estrogen in the oral contraceptive is less than the risk of unwanted pregnancy when using alternative and perhaps less effective contraception. So she would not be advised to cease the OCP. Of the other option, which involve staying on the OCP, it would be preferable to keep her under regular review and reassurance with 6 monthly clinical review and yearly mammography and ultrasound imaging. So option C is correct, which is 6 monthly clinical review and yearly mammography and ultrasound imaging. Screening review to detect familial cancer is usually recommended to begin 5 to 10 years prior to when the diagnosis was made in the relative. Thus, from now in this patient, screening by mammographic imaging, ultrasound imaging, and clinical assessment are complementary to each other, and a combination of regular clinical and imaging review is optimal. For the two blood relatives developing breast cancer before the age of 50 years, she is in a higher risk group of developing breast cancer. Even so, she can be told that 50% of more of such high risk women will not develop a breast cancer in their lifetime. Specialized familial cancer screening clinics are available for such women where genetic testing can be discussed further. Some women at high risk of developing breast cancer may elect to have a bilateral subcutaneous mastectomy performed prophylactically, a procedure bringing the risk of breast cancer development to an irreducible minimum.